Welcome to Emergency Chaos, where we provide tips and tricks to make you a better ER nurse. Today we are going over simple but often overlooked tips when caring for critical patients. Did your preceptor review these? Let's find out. First tip is going to be to never ever let your medication drips run out. These include sedation medications like propofol, Versed, or fentanyl, as well as pressors like norepinephrine, vasopressin, and so forth. You don't want your patient waking up while intubated or their blood pressure tanking because you did not replace the medication on time. A simple fix is when setting up the pump, the volume you input should be less than the actual volume of the medication. This will cause the pump to alarm when the volume is complete, and since you still have medication left, you can program the rest to go in while you go and get a new bag of the medication. If you are adding on a second pressor, you should be advocating for an arterial line and a central line. The arterial line will allow you to better monitor the blood pressure, while the central line will help prevent any complications from infusing pressors peripherally. A central line will also ensure you have trustworthy venous access and can provide multiple lines for different medications that may not be compatible with each other. Tip number 3 is to be aware of the dope mnemonic when your intubated patient starts becoming hypoxic. D stands for dislodgement. Did any of the tubing become undone? O is for obstruction. Is the patient biting on the tube? Is the tubing kinked somewhere? Is there a mucus plug and the patient needs to be suctioned? P is for pneumothorax, so listen to the lungs, recommend a chest x-ray, and E is for equipment. Could the vent just not be working right? So if that's the case, take them off the vent and start bagging them. Tip number 4 is that if you don't have an arterial line but are titrating pressors, sedatives, and giving other medications actively, you should be cycling your blood pressures every 5 minutes to ensure you're closely monitoring how they are reacting. The last thing you want is to be going up titrating on your propofol while your patient's blood pressure is going lower and lower, or to keep going up and up on the pressors despite the blood pressure being stable. Tip number 5 is to label your lines and keep your rooms clean and organized. This is useful so that you can easily identify where your medications are going in case the patient suddenly tanks, or to help prevent errors if medications are not compatible with each other. And if anything happens, it's always best to work in a clutter-free area. Super quick, we have a book for new ER nurses on Amazon that goes over key tips you should master like intubation, strokes, codes, workups, and more. Consider getting your own copy. Thank you. Now, let's do some rapid fire tips. You always need at least 2 IVs for critical patients. You can start levo peripherally if needed. Ensure your rooms have suction and oxygen supplies and be proactive. What do I mean by this? Why is your patient there, right? What complications should you be monitoring for? What treatments can we anticipate and prepare? And if your patient is really critical and starts decompensating but you can't figure out why, check a blood sugar. This has happened to me in the past, and it was the sugar that it was low and there was no reason to check it, but we checked it was low, and that was the cause. Next, for the question of the day, what concentration of dextrose is used for hypoglycemic pediatric patients and why? Again, what concentration of dextrose is used for hypoglycemic pediatric patients and why? The answer is going to be at the bottom of the description text. Now, if you're able to, I would really appreciate if you would become a member. It is $1 per month, and it goes to helping ensure I am able to create more videos like this on a regular basis. Thank you. And as always, teamwork makes the dream work. And here at Emergency Chaos, we are proactive, not reactive.